In this module, we're going to discuss the frequently encountered situation of drug-induced skin disease. Drug eruptions are defined as an acute or subacute reaction to a drug or medicine. And it's important to remember that these are not just tablets or injections. They may be vaccines, inhalers, topical creams may sensitize producing reactions. And of course, we've got to remember things like blood and blood products. It can be some of the most interesting aspects of dermatology, but also some of the most challenging and confusing, as it adds a whole new dimension of potential errors and confusion. If a patient's got a rash of recent onset and they're on 10 different medications, it can be very confounding and confusing. And also, it's often the case that just because you're taking a drug, it doesn't stop you getting either an idiopathic skin disease such as psoriasis, lichen planus, lupus erythematosus, although all of these conditions can be either drug-induced or exacerbated. It also doesn't stop you getting scabies, and it doesn't stop you getting something like secondary syphilis. So just because you're taking a drug, it doesn't mean to say the drug is the cause of your eruption. So what we need to consider are the following possibilities. Is this problem caused by drugs? So in the image here, you can see somebody who's got a life-threatening, a severe skin reaction to a medication. And this condition, called toxic epidermal necrolysis, is pretty much always caused by drugs. So is it a drug? If it is a drug, which drug? Obviously, it's easy if they've only had one medication, but if somebody's, say, on 10 medications, it can be confusing. If it is due to a drug, what else should he avoid if he survives this condition? Are there any other potentially cross-reacting drugs that can produce the same problem? Obviously, we want to know, is this serious? Toxic epidermal necrolysis, without a doubt, is. An exanthematous drug reaction is not. So TEN has a mortality of about 30%, so it's potentially very serious. You're going to ask yourself, if they've got a drug rash, are any other internal organs affected, such as the lungs, the liver, the thyroid, the kidneys? Does he need any specific therapy? And particularly with things like toxic epidermal necrolysis, is he better off somewhere else? People with TEN are often managed in burns units, and the outlook in specialist centres is better than in general centres. So in this talk, we're going to talk about the epidemiology of drug reactions. How common are they? We're going to talk about diagnosis and timing of eruptions. We're going to cover the common problem of drug exanthemata, so-called macular papular or morbilliform eruptions. So 95% of drug reactions are of this type. We'll talk about drug-induced urticaria and also the severe cutaneous adverse drug reactions. They are as follows: acute generalized exanthematic pustulosis, or AGEP, DRESS syndrome, drug reaction with eosinophilia and systemic symptoms, SJS-TEN, Stevens-Johnson syndrome, and toxic epidermal necrolysis. So these are the drug reactions that can make people very ill and do have a potential mortality. I will cover other miscellaneous, such as drug-induced itch, fixed drug eruptions, drug-induced vasculitis, and others. Undoubtedly, the best data that's ever been collected on drug-induced illness was undertaken by the Boston Collaborative Drug Surveillance Program. Now, this was undertaken between 1974 and 1993, so the data is old, but it's really not been bettered. And basically, everybody who was admitted and subsequently discharged from the 3 major teaching hospitals in Boston in the US were interviewed, and they interviewed 48,000 people, and they interviewed them principally about the development of reactions to drugs, not just skin reactions but others as well. they found the following results. 2.7% of people who were admitted to hospital developed an acute cutaneous drug reaction, and 0.1 to 0.3 of these were fatalities. So they died of their cutaneous drug reaction. They were able to rank which drugs tended to produce what kind of reaction. So which drugs were commonly implicated, what type of reactions did that particular drug produce, and they gave us very, very valuable data. So the data here relates to adverse cutaneous reactions only, and they found that 52 out of 1,000 patients given ampicillin developed a rash, penicillin 16, and so on. So you can see that 1 in 20 people who are given ampicillin, for example, developed a rash. And at the other end of the spectrum, they were able to identify drugs that were very infrequently associated with a rash. So potassium chloride, digoxin, aspirin, iron, thyroxine, etc., infrequent causes of eruptions. And there have been a number of studies looking at adverse cutaneous drug reactions in outpatients. But unfortunately, data collection is patchy and sparse and quite variable. So in Italy, they found something like a 2% adverse cutaneous drug reaction. In the UK, a number of studies which have ranged anywhere between about 1% and 6% of individuals who were outpatients who developed an adverse skin reaction. And a number of studies have identified which patients are at particular risk of getting drug reactions. So older people, females more common than men. The presence of an intercurrent viral infection was associated with an increased risk of drug reactions. So as is well known with glandular fever, almost everybody who's given ampicillin who has glandular fever developed a morbilliform eruption. Drug reactions are much more common in people with HIV and people who are infected with herpes hominis virus number 6. Drug reactions are more common in patients with systemic lupus, with Sjögren's syndrome, and those people who have got an underlying chronic lymphatic leukemia. So what are the mechanisms for drug reactions? Well, some are immunological, but many, it's very difficult to classify exactly what kind of immunological reaction it is. But we can see type 1 immediate hypersensitivity reactions. So these produce urticaria, angioedema, and even anaphylaxis. And they tend to be caused principally by proteins. Type 2 are cytotoxic reactions. Well, an example of this would be drug-induced pemphigus. Type 3 immunological reactions, this is immune complex disease, and this produces a condition called serum sickness, and the cutaneous lesions seen in this are vasculitic. Type 4, cell-mediated immunity, well, the paradigm here is of allergic contact dermatitis. So many topical medicaments can produce an allergic contact dermatitis. But we also see systemic allergic contact dermatitis. So this is somebody who's possibly been sensitized topically, but when they take a drug systemically, they get a generalized allergic contact dermatitis. It's possible that some exanthematous and lichenoid reactions are type 4. But as I said, many reactions are not easily classifiable in this simplistic system. So DRESS, AGEP and TEN, the precise immunological mechanism is not completely understood. But of course, there are lots of skin reactions that are not immunological. So let's say if somebody takes an overdose of warfarin and they bruise, well, then they've got a cutaneous reaction that is entirely predictable. They're bruising because they've taken too much warfarin and they have a susceptibility to bleeding. We can see certain reactions where pharmacology can explain the reaction. So aspirin-induced urticaria is relatively well described, and it's due to the effect of aspirin on prostaglandins and leukotrienes. ACE inhibitors can produce angioedema, and this is done mediated through their effect on bradykinin. So there's a pharmacological explanation for these. We see skin reactions to cumulative toxicity. Let's say an example of this might be the blue pigmentation that is developed after long-term use of amiodarone. We can see drugs producing toxicity. So for an example here, individuals who are on long-term immunosuppression, let's say for transplant rejection suppression, have a much higher incidence of cutaneous squamous cell carcinomas. And we see exacerbation of pre-existing skin disease by medications. So we see anabolic steroids producing acne. Lithium can exacerbate psoriasis. So what are the common or important adverse cutaneous drug reactions? Well, we can think of these as being a purely cutaneous problem, or we can see individuals who not only have got a skin reaction, but they've got systemic disease as well. So exanthematous reactions can occur when the skin only is affected, and this is exceedingly common. And as previously stated, about 95% of all cutaneous reactions are of this type and affect the skin only. But in DRESS syndrome, or otherwise termed the drug hypersensitivity syndrome, there may be an exanthematous eruption with other systemic symptoms such as fever, lymphadenopathy, transaminitis, eosinophilia, and a number of other internal problems, more later. We can see skin-only reactions producing urticaria, but we can sometimes see urticaria eruptions with systemic effects as well. So an example would be serum sickness-like illness, where people will get an urticarial eruption associated with arthritis. And of course, acute urticaria may be complicated by angioedema, anaphylaxis, manifest as wheeze and hypotension, collapse, and even death. We can see localized cutaneous-only pustular eruptions, but of course we can see systemic symptoms occasionally with these in acute generalized exanthematous pustulosis. More about this later. We can see localized blistering disease. So an example of this might be a bullous fixed drug eruption. More about this later. But blistering with systemic illness, which might affect, for example, particularly the lungs, we can see this in Stevens-Johnson syndrome, toxic epidermal necrolytis. So these are the more important or the more common skin reactions that we see where their skin or they may be associated with systemic symptoms. So we're faced with an individual who's got a rash and perhaps they've recently started a medication. So we've got to try and establish the following things. We've got to try and determine, well, what kind of rash is it morphologically? Is it like measles, morbilliform, otherwise called exanthematous? Is it urticarial, like nettle rash? Is it pustular? Is it blistering? So it's very helpful to determine what the morphology of the rash looks like. And the reason for this is that, for example, fixed drug eruption is a relatively uncommon cutaneous reaction. But there are certain drugs that commonly do it and certain ones that don't. So, for example, if the patient was taking both ampicillin and phenolphthalein, for example, it's much more likely that phenolphthalein be the cause of the fixed drug eruption. Ampicillin is a very common cause of exanthematous reactions, but a very uncommon cause of fixed drug eruptions. So the morphology of the rash can give you a clue as to which drug is likely to have caused it. We want to know if the mucous membranes are affected. Are there any systemic features? Is there a fever? Is there lymphadenopathy? Is there splenomegaly? And also, are there any associated blood or internal organ changes which may be manifest as an eosinophilia, a high blood viscosity C-reactive protein, abnormal liver transaminase? Are the lungs affected? Is the heart affected? Is the thyroid affected? The chronology of the eruption is also important. That is, when drugs were started and what is the interval or latency between initiation of drug and rash starting. So it's really important to document all the drugs that are being taken by an individual and determine their start and even their stop dates. You want to ask, have they had any of these drugs before? And in the past, have they ever had any previous drug reactions? Also, it's important to act about potentially cross-reacting drugs. So if someone has had a sulfonamide in the past and they've reacted to it, they're likely to react to a sulfonylurea, which might be given to them for diabetes. So it's important to ask about previous drug reactions and anticipate whether there could be cross-reacting situations between drugs. As I say, document the interval between drug introduction and onset, and also determine what response there's been to withdrawal of the drug, and also has the drug ever been re-challenged. So determine the date of introduction of the drug, the latent period, and ask about previous drug reactions. The chronology and latent period for different types of reactions is important and is quite often different between one pattern and another. So the common lag between drug introduction and onset of an eruption, if it's exanthematous, would be anywhere between 4 and 14 days. And of course, a lot of patients might have finished a 7-day course of antibiotics, for example, before their exanthematous reaction develops. Urticaria and anaphylaxis, obviously this is acute onset. It occurs rapidly after introduction of a drug. Fixed drug eruptions, they come on quite quickly, within 24 to 48 hours. Similarly, AGEP, anywhere between 2 and 4 days, so rapid onset. Dress syndrome, however, is often much later, so anywhere between 15 and sometimes up to 40 days after initiation of the drug before the rash develops. Stevens-Johnson syndrome, anywhere between 7 and 21 days, onset of eruption after introduction of drug. Are any tests helpful in determining the cause of a drug reaction? Well, biopsy will only tell you what type of reaction it is, and it won't necessarily tell you which drug has caused that. Prick and RAST testings, this is only valuable in type 1 allergy only, so if people have had anaphylaxis after, let's say, an antibiotic, prick or RAST testing may be valuable. Patch testing, where we put the drug onto the skin for 48 hours, take it off and look and see if there's been a reaction, may be valuable in some eczematous reactions, fixed drug eruptions, possibly dress syndrome. But of course, this is the investigation of choice in determining the cause of allergic contact dermatitis, which of course can be induced by medicaments. Other more specialized tests, such as lymphocyte transformation tests and interferon gamma release assay tests, are research tools only and have a relatively high likelihood of having both false negatives and false positives. So really it's down to what drugs have they had, what kind of reaction have they had, and determining which drug is more probably the culprit. Obviously, it's useful to consult the literature. There's a very good book which is also now available online called LITS, Drug Eruption Reference Manual. And this basically indicates for almost every drug what kind of reaction patterns have been reported in the past, and are they likely to be common, infrequent, or exceedingly uncommon. And LITS is now available online. But of course, one can use Medline, MedWatch, drug alert registries. All may be helpful in determining the likelihood of your suspect drug causing the morphological pattern of reaction that you're seeing. So what are the various reaction patterns, the morphological types of drug eruption? Well, the commonest one that we see is an exanthematous reaction, synonyms being maculopapular or morbilliform. Morbilliform means measles-like. And this constitutes 95% of all cutaneous drug reactions. It occurs much more frequently if an antibiotic, for example, is prescribed with an intercurrent viral infection. Lag between introduction of drug and rash, anywhere between 4 and 14 days. So as previously stated, the drug rash may start 2 or 3 days after the drug course is finished. The rash affects the trunk and extremities. The mucous membranes are usually spared. So you can see in the first photograph a lady who's got this exanthematous drug eruption over a trunk, chest, thighs, and you can see it there in close-up, macular, impalpable actually in this case. If the drug's not stopped, then exanthematous drug eruptions may progress on to produce something called exfoliative dermatitis. But assuming the drug is identified and it's withdrawn, the rash tends to resolve over the course of a week or two. Very often there will be desquamation on resolution. And obviously the differential diagnosis here would be a viral exanthem. Viral eruptions very commonly produce changes on the mucous membranes, and they don't tend to peel as they get better. Now, virtually every drug has been implicated in producing an exanthematous eruption, but beta-lactam antibiotics are the most notorious. So how do we manage this? Well, clearly, stop the drug. If possible, avoid it in the future. Perhaps use a sedating antihistamine if itch is a problem. Give them something like menthol, an aqueous cream, which will help itch. Avoid soap, use an emollient, and a medium potency topical steroid will help symptomatically and slightly hasten resolution of the eruption. As stated, the differential diagnosis would be a viral infection. Now they frequently start on the face, spread to the trunk. There may be conjunctivitis, there may be oral mucous membrane changes, and there may be lymphadenopathy. And these are relatively common in a standard exanthematous eruption. This is just a photograph of somebody who'd got a morbilliform eruption. The drug had to be continued, eventually had to be discontinued because he developed widespread eczematous changes, otherwise called exfoliative dermatitis. So what about an exanthematous eruption with systemic symptoms? So this is the drug reaction with eosinophilia and systemic symptoms. Mercifully, it's uncommon, but it's potentially life-threatening. As stated previously, the latency can be quite long, up to 40 days. It has a number of names. DRESS is the favoured term at present, but other names have been the drug hypersensitivity syndrome and the sulfone syndrome. So the condition will present with a morbilliform eruption, but in addition, there's fever. One of the striking symptoms, and obviously sometimes signs as well, is that of facial edema. So individuals with DRESS quite commonly will have facial edema, and they will often complain of that rather than the doctor noticing it because the patients notice the change. They may have pharyngitis, they may have cervical lymphadenopathy, but they've almost always got eosinophilia, and that can be quite marked. 50% of people will develop a hepatitis, so elevated transaminases. A small amount of individuals get pneumonitis and nephritis. Very commonly, when the eruption resolves, there may be hypothyroidism, so there may be destruction of the thyroid during the course of the illness. Now, DRESS does have a mortality of about 10%. So what are the culprit drugs that are most commonly the cause of DRESS? Well, anticonvulsants, particularly the aromatic anticonvulsants and lamotrigine, tends not to occur with benzodiazepines or gabapentin. Other notorious drugs are as follows: allopurinol, dapsone, minocycline, terbinafine, nitrofurantoin. So these are all well-known causes of the mercifully relatively uncommon DRESS syndrome. So obviously the important thing about DRESS is to think about it, because it comes on relatively long after introduction of a drug. It's easy to overlook that. So the drug must be stopped, and they must be treated with oral steroids, 0.5 milligram per kilogram a day for 2 months. Family members may also be at risk of having DRESS if they have exposure to the same drugs. And as I say, it's important to check thyroid function tests on recovery. It can be a very serious condition. There are people who've developed DRESS and liver failure requiring liver transplantation. Urticarial reactions produce wheals, which are usually transient. And there are a number of mechanisms whereby drugs can do this. Type 1, immediate IgE-mediated hypersensitivity, will come on really quickly, and that's usually due to injection of proteins. So it occurs with blood products, proteins such as biological agents used, for example, in treating psoriasis and ulcerative colitis, etc. So they will come on very quickly. Later onset urticarial eruptions may occur with type 3 serum sickness, and they will take days to come on. We can see what are called anaphylactoid reactions. So an example of a drug producing this would be a radiocontrast medium. So these agents will produce what almost looks like an immediate hypersensitivity reaction, but it's not mediated immunologically. It's a direct effect of the drug causing degranulation of mast cells without involving IgE. Urticaria and angioedema is one of the often late complications of ACE inhibitors, and this is particularly problematic in people of Afro-Caribbean origin because angioedema and urticaria may develop months or even years after starting the drug. So here are the drugs that commonly produce urticaria, anaphylaxis or anaphylactoid reactions, and they're quite a disparate group. So as mentioned previously, proteins, sera, vaccines, particularly those containing egg in individuals who are sensitive to egg, desensitizing agents used in immunotherapy, enzymes and blood. So they're all proteins that can produce type 1 reactions. Antibiotics, probably acting as haptens, can produce urticarial eruptions. Non-steroidals and aspirin can induce urticaria, as I say, particularly because of their effect on leukotriene and prostaglandin metabolism. Narcotics can cause direct mast cell degranulation, as can radiocontrast media and muscle relaxants. So how do we manage drug-induced urticaria? Clearly stop the drug and make certain they don't have it again and don't have potentially cross-reacting drugs in the future. And would use high-dose, non-sedating antihistamines. We can use up to 4 times the standard dose of non-sedating antihistamines. If individuals who got anaphylaxis or airway-threatening angioedema, so anaphylaxis would be manifest by perhaps a widespread urticarial eruption of sudden onset associated with hypotension and wheeze, well, they need intramuscular adrenaline, antihistamines, and steroids pronto. Drugs can produce pustular eruptions. Perhaps the most florid is acute generalized exanthematous pustulosis. An old term was something called toxic pustuloderma. And in this situation, often within days of starting a drug, myriads of non-follicular pustules will develop, start in the flexures on the face, will spread over the body, so the whole body can be covered in these little pustules. It may be associated with fever, and it will last about 10 to 14 days after the culprit drug is withdrawn. So rapid onset, often between 1 or 2 days after initiation of the drug, myriads of pustules with other systemic symptoms as well. So here's somebody who's got AGEP. It's on the limbs, and you can see that in the lower panel, the myriads of these tiny pustules, and where the pustules are broken open, they're leaving little areas of scaling. It can mimic pustular psoriasis, but obviously the clue to the diagnosis is one of the well-known culprit drugs having been started a couple of days before the rash starts. Culprit drugs include antibiotics, calcium channel blockers, carbamazepine. It tends to carry a good prognosis, and withdrawal of the drug, antipruritics, sedating antihistamines to help itch, moisturizers, and topical steroids will usually resolve rapidly. Drugs can produce blisters. So we sometimes see localized blistering over what's called a fixed drug eruption. More about that in a moment. We can see blisters in a condition called drug-induced pseudoporphyria. Again, more about that in a moment. But we can see life-threatening, more generalized blistering in extensive Stevens-Johnson syndrome and toxic epidermal necrolysis. Occasionally, we do see drug-induced immunobullous disorders, so this can be drug-induced pemphigus and pemphigoid. So what are fixed drug eruptions? Well, these occur often within 24 to 48 hours of introduction of a drug, and it will produce an often round or oval acute inflammatory lesion. It may be single, there may be multiple. When they resolve, they often leave quite marked hyperpigmentation. If the individual is exposed to the same drug again, rapidly they will develop a recurrence of the inflammation in exactly the same place. Hence, it's called a fixed drug eruption. Lesions recur in the same place where they've been previously on reintroduction of the drug. Lesions are quite common on the lip, and they can mimic herpes simplex. On the face, as you can see in the upper panel, but very common on the genitalia. So what are the well-known culprit drugs producing fixed drug eruptions? Paracetamol is quite a common cause, but actually, considering how many millions of people take paracetamol, even in the UK every day, it's actually not all that common considering how many doses are taken. Trimethoprim is a well-known cause. Tetracycline, sulfonamides, barbiturates, non-steroidal anti-inflammatory agents. Interestingly, we occasionally see fixed drug eruption triggered by foods. So quinine in tonic water has been implicated, and certain foods such as strawberries will occasionally produce fixed eruptions. Again, the hallmark is every time you have the food or the drug, the eruption comes up rapidly in the same place each time. The most serious and life-threatening of the drug eruptions is toxic epidermal necrolysis. And there is a spectrum between the conditions of erythema multiforme, which may then develop into what's called Stevens-Johnson syndrome, and Stevens-Johnson syndrome can then extend and turn into toxic epidermal necrolysis. So it's an overlapping spectrum condition, erythema multiforme at the mildest, Stevens-Johnson's being erythema multiforme with mucosal lesions and toxic epidermal necrolysis, widespread blistering, full thickness epidermal necrosis, always with quite severe mucosal changes. So here's some clinical examples of erythema multiforme. Erythema multiforme may be triggered by a whole number of things, including underlying illnesses, viruses, mycoplasma, but drugs are a well-known cause, and they tend to produce triphasic bullseye lesions, which often will blister centrally, and they tend to occur more commonly acrally on the hands and feet. With more severe disease, they'll be present on the trunk and limbs. So there's often a central blister surrounded by a triphasic bullseye lesion. Stevens-Johnson syndrome is erythema multiforme, usually with mucosal lesions as well. So you tend to get a severe conjunctivitis, a mucositis of the mouth, and genital blistering and ulceration as well. Stevens-Johnson syndrome may then overlap into toxic epidermal necrolysis. So you can see that happening with more widespread atypical target lesions, which are blistering centrally, and sometimes these blisters will be hemorrhagic. And here's early toxic epidermal necrolysis. So you can see there's widespread erythema, severe mucous membrane changes, not only in the mouth and the eyes as well. But then in the right-hand panel, you can see that there's blistering developing, and the epidermis is shearing away, producing what's called a positive Nikolsky sign. Here are some later features of toxic epidermal necrolysis. So the affected individual is bright red all over. There's extensive ulceration of the back where the epidermis has necrosed and stuck against the bed sheets. When he's sat up, he's got this raw, eroded, extensive area of erosions over his back. On his chest, you can see that the epidermis is sloughed off and it's wrinkled up in areas, rather like wrinkled wet wallpaper. Often severe and hemorrhagic changes in the mucous membranes, particularly on the lips. Mercifully, toxic epidermal necrolysis is relatively uncommon, perhaps one case per million population annually. Predisposing factors: it's much more common in HIV infection, particularly when they're exposed to sulfonamides. It's slightly more common in individuals with lupus erythematosus, and it can occur in a graft versus host disease setting. TEN has a mortality, and it's probably 30 to 40%. So it's a very serious condition that needs immediate recognition and expert management. It's possible to predict mortality by determining what's called the SCORE-10 score. So if an individual's got an underlying malignancy, they've got a tachycardia, they've got stress-induced diabetes, they've got renal impairment, they're acidotic, with more than 10% of the body area being blistered, and they're over 40, all of these give one score. So a score of 0 to 1, relatively low mortality; score of 5, 90% mortality from this attack. Is there a differential diagnosis? Well, yes, there is. There is a condition called staphylococcal scalded skin syndrome, and this is due to an infection with a staphylococcus, which produces something called the epidermolytic toxin. So the photograph illustrated here shows somebody who's got staph scalded skin. So she got an infected wound, skin became bright red, and the epidermis began to slough off. But in staph scalded skin, the mucosae are spared, and the level of split producing the blistering is higher than it is in toxic epidermal necrolysis. So in staph scalded skin, the level of blistering is just below the granular layer. In TEN, there's full thickness epidermal necrosis. So TEN needs supportive measures, so obviously establish the drug, remove the cause, and make certain they don't take any cross-reacting drugs. If someone survives toxic epidermal necrolysis and they have the drug again, there's a very high chance of dying of it. So it's absolutely essential to communicate and make certain survivors have medical alert badges. Here's a list of the culprit drugs. The most frequently the cause of TEN: sulfonamides, tegretol, phenytoin, allopurinol, oxycams. These can all significantly increase your risk of TEN and are the more common triggers. TEN needs managing in an appropriate unit, and very often this is a burns unit. They need fluid replacement, they need temperature control, they'll need enteral nutrition, they'll need antibacterial measures to prevent sepsis, which is the usual cause of death. They'll also need analgesia. The necrolytic process may develop down the upper airway, so they might require ventilatory support, because what happens is the tracheal mucosa might slough off, and that will go down into the lungs and block up the main bronchi. And they may also develop an inflammatory pneumonitis, so they may well need ventilating. So people need to be in burn centres where there's also ventilatory support available. The most important aspect of managing Stevens-Johnson's and toxic epidermal necrolysis is good supportive nursing care, paying attention to fluids, analgesia, nutrition, and early recognition of sepsis. Do specific treatments help? Nowhere near as much as general measures. Steroids, a lot of controversy. There may be a value very early on in the course of the disease, but after a period of time they may do more harm than good. So methylprednisolone may be used for 3 to 5 days in the early course of the disease and then withdraw, because with long-term treatment they may do more harm than good. Some evidence that cyclosporine short-term for 5 days may help. And the jury is out about whether intravenous immunoglobulin high dose is of any help. Drugs can produce itch. So people who've got drug-induced itch will have essentially normal skin apart from excoriations due to scratching. And itch can be due to the drug, or it can occur when drugs are withdrawn. So, for example, during opiate withdrawal and Prozac withdrawal, itching can be a problem. Obviously, other itchy conditions need to be excluded, such as scabies, metabolic causes for itch, iron deficiency, hypothyroidism, renal failure, liver failure, etc., and underlying malignancy, particularly lymphoma, need to be excluded. But the drugs which can produce itch are antidepressants, codeine, tegretol, digoxin, methadone, oral contraceptive pill, indomethacin, rifampicin. Drugs can produce phototoxicity, and this can be dose-related. The usual wavelength of radiation which causes problems is ultraviolet A light. So inflammation, redness, sometimes even acute hemorrhagic changes can occur in the light-exposed areas. So the dorsal aspects of the hands, the face, often they're sparing of the lids, sparing in between the web spaces. So it can be acute. So this man here being exposed to dimeclocycline, and this is a well-known photosensitizing tetracycline, and he developed acute photosensitivity with hemorrhage. It can be low grade, and it can therefore mimic porphyria cutanea tarda, and this is called drug-induced pseudoporphyria. Common causes of the latter are non-steroidal anti-inflammatory agents, but in general the photosensitizing drugs are sulfonamides, tetracyclines, thiazides, nonsteroidals, phenothiazines, tricyclics, fluoroquinolones, amiodarone. Here's a photograph of someone who's got drug-induced pseudoporphyria. So this tends to occur particularly on the dorsal aspects of the hands with fragility and blistering. And it's usually due to long-term use of non-steroidal anti-inflammatories, particularly naproxen. We can see drugs producing photosensitive eczematous or lichenoid eruptions. So you can see an obvious photosensitive distribution of this man's lichen planus-like eruption. It's affecting his face. There's a sharp cut-off where he wears a hat, a sharp cut-off where his skin is shielded by his shirt and collar. So, and again, there's often sparing behind the ears and in the finger webs because these are obviously light sanctuaries. Drugs can produce lesions resembling idiopathic lichen planus. So these are flat-topped, shiny, violaceous lesions which tend to occur on the ankles, wrists, and can spread from there. The lesions can look like ordinary idiopathic lichen planus, but they may have slightly more eczematous features. Perhaps the most implicated drugs are gold, used to be used to treat rheumatoid arthritis. We've got much better drugs these days. Antimalarials, thiazide, ACE inhibitors, beta blockers. Erythema nodosum produces painful erythematous nodules, usually symmetrically on the shins. Although drugs can be implicated, they're relatively uncommon causes. So it's always important to exclude the more common medical causes, which are sarcoid, tuberculosis, inflammatory bowel disease, Behçet's disease. Drugs can do it, and the implicated drugs are the oral contraceptive pill, sulfonamides, and iodides. Drugs can produce avasculitis. So the typical features of small vessel vasculitis is that of a palpable purpura. It tends to occur on the lower legs, 7 to 21 days after initiation of a drug. Perhaps 10% of small vessel vasculitis is drug-induced. Which drugs do it? Thiazides, sulfonamides, phenytoin, interferon, minocycline, vaccines, streptokinase. They're all implicated occasionally in drug-induced, particularly small vessel vasculitis. Topical skin therapy will commonly cause allergic contact dermatitis. We call this medicament dermatitis. So application of the drug to the skin will result in sensitization. Continued application will produce an allergic eczematous reaction. Agents which tend to do it are antibiotics. We can see it from rubber in dressings. We can see it from emollient constituents, even from topical steroids. So this is very often easy to sort out. You can sometimes tell from the distribution. So you see in the photograph of the legs, a man who's allergic to a constituent of his bandages. The lady below, she's been using a product called Herceptin for furunculosis of her nose. She's allergic to both of the constituents, that's chlorhexidine and neomycin. Withdrawal, use a topical steroid, they get better, and you can confirm the diagnosis on patch testing. Drugs can produce pigmentation. So in the upper panel, you can see somebody who had a condition called pyoderma gangrenosum affecting his leg. Healing was affected using an antibiotic called minocycline, but the drug has been laid down in the scar and it produces these characteristic slate grey colour. We can see it from amiodarone, the antidysrhythmic agent, when again it tends to produce blue pigmentation, particularly in the light exposed areas. We can also see it from the antimalarial hydroxychloroquine, tend to get blue pigmentation on the shins and on the palate. Again, we can see drugs inducing the condition called melasma. So this produces pigmentation, particularly over the cheeks. It's often slightly reticular, and HRT and female hormones, oral contraceptive pills, are the best known trigger. We even occasionally see drugs producing skin infarction and ulceration. So the picture shows somebody who has got something called protein S deficiency, and she was over rapidly anticoagulated with warfarin. 2 or 3 days after starting the medication, she developed severe pain and necrosis on the skin over a shin. And this is due to the rapid reduction in natural anticoagulants, which occurs on initiation of warfarin, and you get natural anticoagulant levels dropping before you get reduction in the procoagulants. So there's a temporary period of hypercoagulability, and this is called coumarin necrosis. Mercifully, these days it's relatively uncommon because you don't see it with the new oral anticoagulants, but it's something just to be aware of and on the lookout for. And we can see ulcers caused by other drugs, hydroxyurea, which is used to treat thrombocythemia and polycythemia, and sickle disease can produce ulceration, often after years of exposure. Very painful, tends to occur on the feet and toes. Nicorandil, used to treat severe angina, can produce very painful perianal ulcers, and the mechanism of these, both these ulcers, is not understood. And then we see a whole range of very interesting, unusual eruptions triggered by drugs. So on the left-hand side, the lady with those florid facial lesions, this was due to exposure to iodides in radio contrast medium. She'd got some degree of renal impairment, and this is a condition called iododerma. Next to her, the facial eruption, this lady's got topical steroid-induced rosacea, so another form of drug eruption, steroid-induced rosacea. The man on the right, the upper panel, he's been treated with a anthraquinone-containing laxative. The laxative is an irritant purgative, and unfortunately he had overflow incontinence, and the product has produced an irritant eczema where he's been sitting in his incontinent feces. Lower panel, this is somebody who's got long-standing psoriasis, but certain drugs can make psoriasis worse. Terbinafine, beta blockers, lithium, ACE inhibitors are the best known. Some other oddities to keep us entertained and interested. On the left-hand side, you can see this unusual eruption on the back of the hands. It was symmetrical, also associated with nail dystrophy. You can see that she's got pigmentation of the nail on her thumb. And this is due to long-standing hydroxyurea, and it's an eruption which almost mimics lupus erythematosus or dermatomyositis, and it's called hydroxyurea hydroxycarbamide dermopathy. The buttock lesions, this is somebody who's given intramuscular iron, and the iron is staining her skin from where it was injected intramuscularly. Some more oddities. The little girl on the left has got hypertrichosis, and we occasionally see this with minoxidil, which is occasionally used to treat severe therapy-resistant hypertension. On the right, you can see somebody who had taken a barbiturate overdose, and she's got pressure blisters. So some more oddities to keep us on our toes and to keep us looking out for.